Good afternoon, all. Let me congratulate the organizers of this GAF for having organized it very beautifully, even in this pandemic situation. And let me thank the organizers for giving me a chance to present a paper on diagnosis of headache. So, can I start my screen sharing?
Yes, Dr. Jeena, please start.
Okay. Hope you can see the screen properly.
Yes, it's seen.
Yes, ma'am.
Okay. So the topic given to me is diagnosis of headache. Actually, as we all know, headache is a very common complaint. I think in our OPD, 50% of the patients coming to Shalakya OPD complains of headache. And there are n number of reasons for headache. That is the main difficulty faced by the practitioner to diagnose the headache. What is the reason? What is the etiological factor behind the headache, or what causes the headache? Maybe most of the headaches are tension related, or maybe uh, purely psychological. So once we diagnose the cause of the headache, we can easily solve the problem. But if you are not getting the proper etiological factor or the reason for headache, it's very difficult to treat also. That is my experience. And it's a very common complaint. I think every one of us had headache in our life multiple times, maybe due to many reasons. And identifying the proper cause is a challenge faced by the practitioner. And right diagnosis is the key to the right management. Then only the patient will benefit from the treatment. If the diagnosis is perfect, the treatment will be more easier, and we can manage the with proper drugs when we can diagnose the headache properly. And for this, the etiological factors has to be thoroughly analyzed, because in many cases of headache, just removing the etiological factors relieves the headache permanently. Like maybe the patient is having some psychological distress due to some family problems or some other issues, it is precipitating as headache. So once the factor is identified, it is easily curable. Always I remember of a case approached in my OPD, adolescent girl. Maybe she is 17, 18 years old, and she's recently married also. And she had headache for the past few months. And her in-laws brought the patient to the OPD. And once I gave some medicines and she came back, but there was no relief. And then I interrogated the patient thoroughly. And then I came to know that she had some personal problems in her in-laws' house, and that was the cause for the precipitated headache. So once that was settled, her headache was permanently cured. Likewise, once we identify the etiological factor, we can give treatment or give some relaxation techniques, or maybe some yoga. Everything will be helpful in managing headache. And the clinical history has to be taken very perfectly, and the diagnosis mainly depends on the this history. I think the investigations, if we go, there are n number of investigations from X-ray to MRI scan. We have lot of investigative procedures, but most of them are expensive and not affordable to the common population. So we can't give a prescription for doing an MRI to a layman, because it costs 5,000 to 6,000 rupees, and the patient may not afford to do that. So we can diagnose the headache from other without investigation. We can try to diagnose the headache with other means like history taking. And the importance to be given to the site of pain and the onset of pain, the characteristics, how the pain occurs, what type of pain, and radiation. Is the pain located to a particular place, or is it radiating to some other region? And the associated symptoms, as Manjusha madam told, like migraine cases, it is commonly associated with nausea or vomiting. And the timing of headache, the some type of headache, cluster headache, it's usually seen in the night time. So the timing of headache is very important, and the exacerbation factors as well as relieving factors, I think that is the utmost important one in the diagnosis of headache, as Ayurvedic physician is concerned. Because by considering the exacerbation factors or the relieving factors, we can come directly to the dosha involved, and from that itself we can give the medicines against the dosha predominance, and the patient will get faster relief by adopting such treatment. And the severity of the pain, how much pain the patient is having, is it disturbing his regular duties, everything. And coming to the site of the pain, see, if the pain is unilateral, madam told that is migraine comes from the word megrim, which means hemicrania, half part of head. So usually the migraine is having unilateral origin. So unilateral pain may be due to migraine or cluster headache. And if the patient is having bilateral headache, we have to rule out tension headache also. And coming to the ocular pain, if patient is having pain on the eyes, it may be due to cluster headache or due to some ophthalmology causes, like even due to astigmatism. The patient is having asthenopic symptoms which causes pain in the eye. And migraine, that also causes ocular pain in some patients. And coming to paranasal area, if the patient is having tenderness in the paranasal regions, then sinusitis should be ruled out. And localized, then diffuse. First the pain is localized to an area, then the pain is spreading all over. That may be a cause of raised intracranial tension, which is due to an intracranial mass. The occipital pain, the pain, sometimes the patient complains of the pain on the back side of the head. It may be due to meningeal reasons, hemorrhagic reasons, or due to related to eye problems may also precipitate occipital headache. And on the course of a nerve, we know that post-herpetic neuralgia, it's a severe painful condition. After herpes, the patient is having pain on the course of that nerve. And the supply area of nerves like neuralgia, we know the glossopharyngeal neuralgia, trigeminal neuralgia, such neuralgias are very common nowadays. And then we have to consider the onset of pain. Onset, is it acute or subacute or chronic? That also lead to the diagnosis. Acute onset is usually meningeal, hemorrhagic, or cluster headache. In cluster headache, the patient gets up from the sleep at midnight due to severe pain. Or subacute onset is maybe due to intracranial mass or raised intracranial tension. And the chronic type of headache is usually due to migraine, or it may be due to tension headache also. Sometimes the patient come to us with headache, and when we question the patient or interrogate the patient tells that she's having severe headache. And once we interrogate thoroughly, she's telling her children are having exams at school, and at the time of exam she regularly gets headache. That's only due to tension. So we have to rule out such problems also. And coming to the characteristics, we know that migraine or tension headache, usually it is pulsating or throbbing type. And in tension headache, it's described as a tight band over the head. That is a sense of tightness or pressure as the main characteristic feature of tension headache. And in neuritic case, that it is sharp lancinating pain, like trigeminal neuralgia. The patient gets the pain on and off, but once the pain is there, it is sharp and lancinating in nature. And sinusitis, we get tenderness over the sinus. And if there is mass in the brain or mass in the intracranial mass, the pain is dull, not a severe lancinating type of pain, but the pain is dull and it is steady. It is always there. And coming to radiation, The tension headache may start in the occipital region and it may radiate to all over the head. That is usually seen in tension type of headache. And in migraine also, it's unilateral usually. So it starts in one side of the head, but it spreads to the other side also later. And coming to the associated symptoms, these also associated symptoms also may give a clue to the diagnosis of headache. uh, the visual symptoms, associated symptoms pertaining to vision are ocular type of headache, migraine, or optic nerve involvement, or visual pathway lesions, all may have associated symptoms in eye. And nausea and vomiting usually seen in migraine or intracranial mass. Once a patient who came, a girl with 21 years old, she has a small child also. She came to the doctor with a severe headache, and she told it occurs on and off. And she asked whether to take an MRI or some scanning. But doctor told she just take some medicines and we'll see what to do. And the patient went back, and later the next week also the patient had severe headache and she collapsed, and she, very sad to say, she passed away. And it was very sad thing that the doctor couldn't identify that the thing was it was an aneurysm in the brain, but it didn't give any clue other than this headache. The photophobia usually associated with migraine and also with meningitis. So if the patient is having photophobia, don't neglect it by saying that it may be due to migraine. Always we have to keep in our mind that meningitis also may cause photophobia. Ipsilateral rhinorrhea and lacrimation, that is a typical characteristic feature of cluster headache. You get discharge from one eye or one part of one nostril, that gives us the clue that is the cluster headache. And myalgia and tension, we have severe body pain along with headache, and this gives us a clue that it is maybe due to the viral infection. We know that from diseases like chickenpox, before the disease starts, like the blister formation or the fever, everything, before everything, headache is seen for the first time. And weight loss of the patient has to be taken care of, has to be taken care importantly, because it may be due to mass in the brain. And the fever and chills, that may be due to the systemic infections, or it may be also due to meningitis. And the time of headache, the end of work or end of a day, the patient is having headache, that may be due to eye problem, or it may be due to the tension headache. The patient is working in the office, so after the office hours she regularly gets headache. That means her office work is troubling her and she's having some tension headache. Or the patient is having some astigmatism or asthenopia, and due to regularly using the system or some paperwork, she's having the headache. That means eye problem has to be ruled out. And awakening during sleep on the same time each day, that's what I told. Every day, every night, 2 a.m. the patient is getting up from sleep with severe headache. That is 100% we can diagnose it as cluster headache. And awake from sleep, it's also sinusitis. Sinusitis, if all the sinuses are severely involved, the patient gets severe headache and during sleep also, because all the sinuses are getting congested due to the fluid collection in the sinus, and it may be due to mass in the intracranial cavity. An episodic type of headache, which is lasting for 4 to 72 hours, that is migraine. Some patients may get every week, or some every month or fortnightly. The headache is coming and going regularly. So it's a clue for diagnosing it as migraine. And the exacerbating factors, this is what I told, we have to give utmost importance. In migraine, emotional stress, fatigue, menstrual period, lack of sleep, and some food items, as Madam Manjusha Madam told, old cheese or some chocolates or red wine, all are the culprits, all are usually known factors for causing or triggering factors for migraine. And temporomandibular joint dysfunction that causes headache or facial pain on chewing. If we get headache on chewing, we have to rule out the TMJ dysfunction also. And the cough induced headache, the patient is having headache on cough or straining, even during on if the patient is having constipation or straining at stools, even that causes headache. Means usually it is a structural lesion of posterior fossa. And exposure to cold causes headache. The patient is having head bath, the next after having head bath, immediately the patient gets headache. Usually it's due to the sinusitis or kapha dominance. Intracranial neoplasm. This headache worsens on talking or physical exertion, like climbing stairs or lifting weight or talking more. Everything worsens the headache, and which increases the severity. After the pain becomes severe, the patient becomes stuporous also. And coming to severity, severity is assessed by uh, if the headache interferes with a normal routine like sleeping or talking or eating. A regular affairs are interrupted means it is severe. A better approach is to ask the patient to give the pain point. We can give a scoring like 1 to 10. We can ask the patient because pain is purely subjective, it's not objective. So we have to know the severity of pain. We can ask the patient, you give a score between 1 and 10. So by the from the severity assessment can be done by the pain scoring also. Usually there is a concept of a headache diary. I think many of you might have heard about that. Headache diary. The patients who are having chronic headaches, usually we ask the patient to keep a record with them, like the time of the onset of headache or the duration of headache or by what intervention the pain is relieved. Everything they can not note in the diary, and once the doctor goes through the diary, we can get a clear cut idea about the dosha involved or the type of headache. And coming to investigations, I know I told you that there are so many type of investigation, but these are the most important things I consider for diagnosing the headache. One is the previous history. We have to know what when the patient had the headache before, and the character of discomfort. It is a band-like feeling, or it's a sharp lancinating pain, or some piercing type of pain. So what is the character of discomfort, and the distribution of pain, time of onset? Is it continuous or periodic? Uh, as in migraine, we can see that it occurs periodically, or is it continuous? In the tension type of headache or some intracranial mass, the pain will be continuous. And the precipitating factors, family history is also very important. Like in the case of migraine, usually there is a positive family history, and the personal history is also important. We should know the patient is having some alcoholism or cigarette smoking habit, or some other um, habits which cause headache. Manjusha madam already told that in south, every daily they do head bath after applying oil. Maybe that may be the reason of headache, or after applying oil they are going out and in the sunlight, that may be the cause of headache. So we have to know the personal history also. And the common causes of headache, we all know referred pains are there, neuralgia is there, glossopharyngeal, trigeminal neuralgia. Trigeminal is more common, glossopharyngeal also is there. Meningeal irritation in the meningeal structures, vascular causes, or traction on intracranial structures. Traction may be due to the CSF leakage or something. Traction may be there on intracranial structures, which causes pain. And the important cause is psychogenic cause. In many cases, I think 50% of headache cases are psychogenic. And the miscellaneous causes, like due to coital headache, or exercise induced headache, everything is less common, but they are there. And clinically, we recognize these types of headache: chronic and progressive type, recurrent paroxysmal headache, acute episodic type, and other types of headache due to local cause. Local cause means there is a dental caries, the patient is having pain and also the patient gets headache, or the patient is having local sinusitis of the maxillary sinuses, the patient is having headache. So due to some local causes also the patient may get headache. And the chronic and progressive type, usually suggestive psychogenic type, intracranial neoplasm, uremia or other toxic states, and syphilitic meningitis. It is there in the textbook, but nowadays syphilis is very less seen in our society because of the introduction of all the uh, what contraception, everything. Syphilis has very has come down dramatically. Industrial toxemia, some due to some occupational hazards. Industrial toxemia is there that may cause headache. So we have to know the working atmosphere of patient also. Recurrent paroxysmal headache, usually migraine or unresolved cerebral condition. Once there is a cerebral condition and it is not resolved properly, the patient may get recurrent headache. And arterial hypertension, that is a very common cause for headache. We can give some antihypertensive and thus the headache can be controlled. Cervical spondylosis, usually it causes occipital headache, and the reason may be the cervical spondylosis. So the patient should be treated for the cervical causes, then only the headache will come down. And acute episodic headache, we know fever, influenza, malaria, infectious diseases, alcoholic excess, that is termed as hangover headache, and head injury or subarachnoid hemorrhage, intracranial hypertension. These all are usually the causes of acute episodic headache. And this I have already mentioned the local causes: ocular, sinusitis, disease of skull bones, etc. You can see the area where pain is there in this chart. These are the causes for having headache: dehydration or caffeine withdrawal, injury, heart disease, everything causes may cause headache. And this is a concept: abdominal gas, is it related to headache? Is it a reality or a myth? I think allopathy doctors will not agree with to this factor, but as Ayurveda physician, we know that digestion is very well connected with the headache, and if once we have proper digestion and proper passage of stool, uh, we have less chances to have headache if there is no other causes. Some patients come to us and tells that there is headache, and when we ask the history, the patient tells that she is constipated and she didn't pass stool for the past few days. So just giving a laxative or purgative can relieve her headache. I have seen some cases like that, because we have in Ayurveda we have studied that Shagrut Rodha. Shagrut Rodha is the symptoms of Shagrut Rodha. Headache is mentioned. And when to worry? See, headache is a common symptom seen in many patients. The patients are worried. They think that they are having some tumor or some hemorrhage, or they are going to die. They are always worried about headache, because we have heard that many conditions which causes the death of the patient only due to headache. So the patient come to us and tell that, oh, I'm having headache for the past three few years. Is it some tumor or something? The patient is worried. So when to worry? That the doctor should know when to worry, because these are the red flag signs in headache. We know when to refer the patient to a specialist, or when to do investigations. That is the these are the symptoms. Loss of vision. The patient is having headache, but one sudden morning the patient lost vision. So it's a matter to worry. Drowsiness. The patient is more drowsy. So that is also a red flag sign. And there is confusion. The patient is having confusion or memory loss, or high temperature with headache, or stiff neck. Stiff neck, we know it is associated with usually meningitis. Unexplained vomiting. Unexplained vomiting means the patient is not having it's not having a chronic headache or anything, but one fine morning she had headache and she vomited, or she had some trauma of the day before, the next day she vomited, she had headache. So that is a symptom to worry or to take care of. Headache associated with postural change or sneezing or coughing or physical exertion. I already told that it's usually related to some intracranial problems. And new onset after the age of 50. See, in migraine, it is always the starting of migraine is usually during the adolescent period or the early adult life. So the patient is not having headache till the age of 50, or then suddenly she started headache. We think that it is migraine, but we have to do the investigation to rule out the other intracranial causes. And below the age of 10 also, it is comparatively less. And progressive headache worsening over weeks. We get more and more headache. The severity increases. That means it is a matter to worry. Thunderclap headache, the sudden occurrence of headache, that is thunderclap headache. And a diagnosed CA patient is having headache. That is also a matter to worry. Maybe that is due to a metastasis. So we have to exclude all that in a pre-diagnosed CA patient if the patient is having headache. This is the algorithm for headache diagnosis. First, detailed history and examination, and rule out the headache alarms or red flags present. Red flags I have already told you, so we have to see any red flag is present. If it is present, so we have to do some test. So exclude the secondary headache using appropriate investigations, maybe a CT scan or MRI scan, whatever the case demands. If there are no red flag signs, we can consider it as a primary headache. But then we have to see whether the patient is having atypical features. If the patient is having typical features of migraine, it's well and good. We can treat it patiently and calmly. But if there are any atypical features, we have to again reconsider the secondary headache. And if there are no such atypical features, we can diagnose it as a primary headache disorder and treat well. So this is the algorithm for headache diagnosis. And the treatment of migraine, we know avoiding triggers, alcohol, food, hunger, irregular sleep, everything. I think Manjusha madam already have covered the migraine topic, so I'm not going into detail. And when is neuroimaging needed? Neuroimaging, when is it needed? CT scan or MRI scan? Individual basis. That is the first and foremost thing, individual basis. The patient is coming to you and she's telling that she's having headache for the past months or few years, and she demands a CT scan or she demands an MRI scan. We know that as doctors we can deny that, but better not to deny. If the patient demands an imaging, better go with that, because if we miss a cause or some intracranial cause, it will be a great damage to us. So the individual basis, some patients we know they are very much tensed or psychologically very imbalanced. So such patients may may have some reassurance also along with the treatment. And if there is red flag features, any red flag feature is there, neuroimaging should be done. And the patient is not responding to any of our treatment. We are giving so many medicines. We are giving Pratyakshadatradi Kwatha, Varanadi Kwatha, Varanadi Grida, Shira Shuladrija Vajra Rasa, or there are n number of medicines also in Ayurveda. But the patient is not responding. She is still having headache, means we have to go for a neuroimaging. Subdural hematoma, it's a known culprit for causing headache. So we should rule out all this. Intracranial hemorrhage and midline shift. Usually it is the prognosis of treating such intracranial problems depends on this midline shift. So the MRI scan shows the normal midline and the midline shift also. And 1/3 of migraine sufferers it is a recurrent headache disorder and unilateral pulsating moderate or severe. This is easy to diagnose. Migraine is, I think it's the easiest thing to diagnose, but treating it's not so easy. We have lot of medicines, but maybe many a time inpatient treatment is also necessary along with the medicines. So these are the possible triggers. We have already gone through that. The cluster headache. It starts and ceases abruptly. And
just may I interrupt?
Yes, madam. I'll finish it soon.
Yeah,
I'll finish it. For sinusitis also, we know that the tenderness or the how it is presenting, acute type, subacute, everything we have to diagnose. And the features: nasal congestion, cough, malaise, nasal discharge, everything gives a clue to sinusitis. We can take an X-ray or a CT scan, anything. The reassurance, the management part will be dealt by some other faculty, but reassurance is the most important thing we have to give the patient along with the medicines. For this, I've already covered this topic, differential diagnosis. Okay, so we don't have more time. So I think I have covered almost the important points for diagnosing headache. So let me, the Ayurveda treatment will be covered by Dr. Sri Kumar. So to conclude, headache is the commonest but the most difficult clinical problem, and care should be taken before attaining a clear diagnosis, because there are a lot of types of headache. There are many causes for headache, and some may become fatal because they are not managed well. Thank you so much.